Good morning. Hello. There'll probably be people wandering in, but I think we can cope with that. There'll be a few hold-ups with the fabulous spring day. I'd like to welcome everyone here today. My name's Ellen Kerins, and I know quite a few of you, I think, from either the Cancer Council or Health Consumer Alliance, or currently I'm working with the Aged Care Royal Commission Community Engagement team, so probably know a few of you from across those networks. But my role today, or why I'm standing up here, is that I'm currently the chair of the SAHMRI Consumer Advisory Group, and there's members of that Consumer Advisory Group here today, and you'll get to meet them as the day goes on. But what I thought I might do just for a minute before I introduce Tony, a member of the Consumer Advisory Group, is just reflect on the history of community forums. So this is our second community forum, and we had one last year, and you contributed quite a bit of advice in the evaluation of that community forum. And some aspects of that advice for this year's community and forum that you'd like to see were some concrete examples of consumer engagement in research of how it happens now. So hopefully we'll address that to your request today. You also wanted to see examples of how community engagement in research is useful. So we've included that in today's program. And probably the most outstanding piece of advice that you gave us that we've picked up is that you wanted consumers involved in developing the program and influencing the program, and actually on the day having time for consumers to contribute or community to contribute to aspects of going forward with our work with SAHMRI. So I thought the next person that we would have up to welcome you would be Tony Sangster, who's a consumer community member of the Consumer Advisory Group, who led the working group for today's community forum. Then I'll come back with some welcomes, and then I'll introduce Alex Mickelmore, the Senior Project Officer for SAHMRI and Health Translation SA, to talk about what we've done in the last the last year since we met. And then there'll be some presentations around consumers in research, and then there'll be some tasks at the tables. So that's the program, but you would have seen that when you registered. So I'll hand over to Tony to cover off a couple of other details. So welcome.
Thank you, Ellen. I have to say that the forum committee that arranged this has done a marvellous job. I can't take much of the credit at all, because it is the committee that has done this. It's my task to help you settle in, and part of that involves knowing where the coffee and tea is. Probably caffeine's the most important medication involved today. Also to mention that bathrooms, ladies that way out and gentlemen that way. Also, if there should be a flood or fire or whatever, we go straight out the front door and congregate near the Ra Hospital. Let's hope that doesn't happen. You will all hopefully have got name tags on, and to remind you that there will be photographs taken and a recording of this. Obviously, we'd like people who can't attend today, and people particularly in the country, to be able to see what happens at this sort of meeting. So could you please make sure you've got a sticker or something that I think is available at the desk to show if you don't wish to be photographed or recorded, please, just so we know. Okay. The other thing is to talk about what might come out of this for you from this this particular forum. And the particular areas we're looking at is the fact that you're meeting people that you may know, but also people that you don't, and that may form some networks and some mixing of things. To update where the advisory committee is done, particularly since the last forum, and see what sort of progress there is. To also learn from the presentations about what local examples there are of where community have been involved with researchers, and to point out that this is called a community meeting, but it's also about researchers as well, and the interaction between the two. And finally, the idea of particularly the workshop part of this to make to get sharing of ideas that can help move things forward. Okay, Ellen.
Back again. So before we start, we'd like to have an acknowledgement of country, and today we acknowledge the Kaurna people as the traditional custodians of the Adelaide region, and we recognise their cultural, spiritual, physical and emotional connection with their land. We honour and pay our respects to Kaurna elders, both past and present, and all generations of Kaurna people now and into the future. And before we kick off with Alex's presentation, we have a message from Steve Westling, the Executive Director of the of SAHMRI. So as you can see, he's not physically here. He's in Canberra at a meeting, but he felt it important to provide a message which you can read. So he's saying that on behalf of SAHMRI and Health Translation SA, he'd like to welcome you to this year's Connecting with Community Forum. He's reinforcing the commitment to community engagement in health and medical research that has been made, and the progress that's been made, and the ongoing work about developing supports, information resources and networks to enable this to happen more easily. And thanking you for coming today, your interest and input, and looking forward to hearing the outcomes of today's session. And Alex will refer to this, but the Consumer Advisory Group of SAHMRI actually reports through Caroline Miller and Steve Westling to the SAHMRI board. So that's our governance connection with Steve, who remains interested, as always, in our work. So to hear a little more about our work, I'd like to invite Alex Mickelmore to give you an overview of what's been happening with SAHMRI and with HTSA. So, thank you, Alex.
Thank you for the introduction, Ellen, and it's wonderful to see so many of you here today. As Ellen mentioned in the introduction, this is the second time Health Translation SA and SAHMRI have hosted this event. So we thought it was important to give you an update on what we've been working on throughout the year. So with that in mind, the few things that I wanted to briefly cover today were around the SAHMRI Community Advisory Group, the SAHMRI Board Ambassador role, the Community Interest Register, the Community Engagement in Research Toolkit, some national work that we've been involved in, and then what we're thinking are some of the priorities into next year. So at the beginning of this year, SAHMRI sent out an expression of interest for our Community Advisory Group, and we appointed 5 community representatives from that process. We also have representation from each of the SAHMRI research themes, Health Consumers Alliance, and SAHMRI and Health Translation SA operational teams. So as Ellen mentioned, she's the chair, and really the aim of this group is to help drive implementation of our SAHMRI Consumer and Community Engagement Framework. And I guess the big difference with this group compared to a previous committee we did have operating was that we do now report directly through to the SAHMRI board. So a recent example of this was that Ellen chaired Ellen attended the August SAHMRI board meeting to present our community engagement report for 2018-19, as well as discuss progress against implementation of the framework. And this was really well received by the board members. And there should be a copy of the report on your tables if you haven't seen that already. So the priorities identified for this group for this year were to implement a community interest register, hold a community engagement forum, which is what we're doing today, make community engagement resources more accessible to both consumers and researchers, and then also establish a evaluation framework to capture information that will help us evaluate the broader SAHMRI framework into the future. And I'm pleased to say that we're on track to achieving all of those things by the end of the year, or at least before I go on maternity leave. So when Ellen attended the August SAHMRI board meeting, she floated the idea of appointing a board ambassador for community engagement, and this has since been endorsed by the board members, and we're just working through at the moment which of the existing board members will take on that role. But we envisage that this person will be responsible for ensuring the board champions the SAHMRI framework, both locally within the state but also nationally. They will act as the link between the board and the advisory group, and they will also present any associated awards and recognitions throughout the year that we have. And we're really pleased that we now have this level of support and recognition for this work across the organisation. So one of the really big achievements for the year has been the launch of the Community Interest Register. And this provides SAHMRI and Health Translation SA with access to a database of community members who are really interested in health and medical research and want to be involved in our work. And so we can use this as a tool to help promote community engagement activities as they come up throughout the year. The register was developed by a small implementation work group, and it captures basic contact details, areas of interest or experience of the community members, and we're also at the moment asking some optional feedback questions just around the usability of the register itself. So in terms of next steps, we would like to do some further promotion of the register to obviously have more people involved in the work that we do. We want to make some improvements based on those optional feedback questions if we can, but we are kind of limited within the program or software that we're using. And we're just starting to think about how we might be able to take the register and expand its use across our partner organisations, so that being the universities and SA Health, so that we're not duplicating and all of those organisations have access to that pool of people. So for community members who may not be familiar with the register, I just wanted to show you how you can access it. So this is a screenshot of the landing page on the SAHMRI website where you can go to join up, and there is an online registration form, as I mentioned, but there's also a hard copy registration form that you can complete and send back in to me. Alternatively, you can always contact me and I can do it over the phone with you. But there are copies of the hard copy registration form on your desk, and you're welcome to do that today as well. For SAHMRI and Health Translation SA researchers who might want to send out an expression of interest for a community engagement opportunity, we've developed a request form, and this is available via the toolkit, which I'll talk about more in a minute. But the form just gives me some background to how you would like to involve community members in your research projects or activities, and then I generally will follow up with a meeting to work out how we best do that from there. So the form can be completed and emailed back to that generic community@SAHMRI email, and that comes through to me. Moving on to the toolkit. So we haven't officially launched this yet, but this again has been developed in consultation with a small work group of community members and researchers. And we wanted to have one central location where community members and researchers could access really practical tools and resources to help to help this work across both SAHMRI and Health Translation SA. So at the moment we've got things like example terms of reference, how to send out an expression of interest, the reimbursement forms for community members, and we'll keep adding to this over time. So while these resources are SAHMRI and Health Translation SA focused, we're really keen for other organisations within South Australia more broadly to adapt them for their use. So in terms of next steps for this, the work group has identified a number of additional resources that we would like to develop, and as these become available, we'll upload them onto the website. So please do keep checking back. There'll be more things over time. And as Ellen mentioned, one of the table discussions later this morning is actually focused on trying to put together some content for one of the resources we want to develop. So you'll have an opportunity to input into this as well. The toolkit can be accessed via the resource tab on the Health Translation SA website, which looks like the screenshot up there. You can filter based on whether you're a consumer or a researcher. We'll look at them all together. And then the resources themselves look like this on the web page. So there's different resource icons at the top. So for example, factsheet or policy, or whether it's just a general resource. There's a short description of what it is, and then there's a button for you to download a copy of it. And finally, I wanted to mention about some national consumer and community work that we're involved in through the Australian Health Research Alliance. Health Translation SA is a member of ARA, and a key outcome of phase 1 of the national project that's happening at the moment was the publication of an Australian-wide audit report, which summarised results of a national survey into the extent and nature of consumer and community involvement in health and medical research. So together with the findings of this survey and a literature review, they have informed 4 priority areas, which are listed on the slide there. But Health Translation SA has put up their hand to support the research and evaluation recommendation, and will work with Sydney Health Partners and regional health partners to develop two key projects. So the first one being a position statement, which will summarise the evidence that indicates the importance of community involvement in research, and then secondly to identify and trial some evaluation tools to assist in measuring the impact of community involvement in research. So this work is very much at the beginning, but once those resources are available, they'll be added to the toolkit. In looking forward to next year, we would like to further promote and refine the tools and resources we have developed during the last year, so that being the register, the toolkit, etc. We're really keen to offer some shared learning opportunities between researchers and community members, and I think initially this might be in the form of some orientation sessions for community members that have recently joined the register. We'd like to strengthen relationships with our partner organisations, so that being the universities, SA Health, Health Consumers Alliance, and look for opportunities for joint activities that become more statewide. And we'd also like to play an active role in the national work that's happening as this starts to ramp up. So I hope this has been helpful, and please feel free to come and ask Ellen or I about any of the topics that we discussed today. And yeah, thank you all for coming.
I'm back. So the next section of the agenda, which falls back over the commentary and the evaluation last year was to look at community voice in research and priority setting. So we know that involving community members in research priority setting is still new, and today's presentations provide some examples of how it has been done so far in South Australia. So we'll have three presentations. One of those will be a dual act, and we'll have a question and answer session at the end. So I'm suggesting you hold on or write down your questions, and we'll have each presenter come and sit here, and we've got roving mics. So while you're listening to the presentations, try and work out what it is that you would like to know. The speakers will try and stick to time because it's a pretty tight schedule today, but we'll try and keep it moving as quickly as we can. So there's a small operational group that works with Alex, which includes myself and Caroline Miller, who's here from SAHMRI, the Executive Officer, and also Wendy Keach, who couldn't be here today. She's the Chief Executive of Health Translation SA. So the first presentation from Health Translation SA will be presented by Jenny Carr, and some of you may well know Jenny. Jenny's a Senior Project Officer within Health Translation SA and provides executive support to the Board of Partners, as well as managing several other strategic projects. She enjoys working in partnership with consumers, has spent time working with Health Consumer Alliance, and also enjoys working with health professionals and other stakeholders to improve health outcomes for South Australians. So I'll introduce Jenny, and then we'll have two more speakers before we start the panel. Okay? Thanks, Jen.
Hi, I live in fear of being dinged by Ellen. Every time I present, I get dinged. So I have practiced this. I'm a little bit over, but hopefully I can speed it up. As Ellen said, Jenny Carr, I'm Senior Project Officer with Health Translation SA. Wendy sends her sincere apologies that she couldn't be here today. So, okay, I know that many of you probably came to the forum last year, but I think it's probably important that I just give you a little overview of who we are and what we do. I think a few people still are a little bit unsure about what health translation is and why we need to exist and so forth. So to start with, I'll just say that we are an NHMRC, National Health and Medical Research Council accredited academic health and research translation centre. We were accredited in 2015, and we're one of the first of 4 RTECs, is what they're referred to as, that were accredited in Australia. There are now 9, and they make up the Australian Health Research Alliance, which is what Alex referred to previously about that national organisation. So we're one RTEC. So in 2015, when we were formed, there was no funding associated with that accreditation, but we established ourselves. We're a virtual organisation made up of a number of partners. We've got the 3 universities. We've got SAHMRI, the Aboriginal Health Council, Health Consumers Alliance, SA Health, and the 2 PHNs, Primary Health Networks. We are based at SAHMRI. They're our administering agency. Our job, we're around enabling research findings to be translated into action to ensure that health research can positively impact on the health of all South Australians. That's our mission. I should say we're led by a board of partners, and it's a representative board, and so all of our partners have a representative on our board. So why do we exist? Well, we do know that it takes 17 years for a percentage, and not all, of new scientific discoveries to enter day-to-day clinical practice. So our job is really around speeding up that translation and the scalability of that research. Traditionally, a lot of research has been around publication and winning new grants. Our role and our job is around ensuring that some research starts to focus on the impact. For example, looking at what is the improved health outcomes. And our job as a translation centre is around providing leadership in that field of research translation and bringing together the academics, researchers, clinicians, policymakers, stakeholders and community members. And we're very much around that idea of fast tracking it, making it happen much more quickly. Most of our work is around collaboration. We spend a lot of time pulling people together, getting them to discuss and work together on projects. So here is our goal, which is to accelerate the translation of research along the impact pathway for better care. You'll hear this term impact pathway. It's a research translation impact pathway, and you'll hear that term impact pathway whenever you're discussing research translation. I have put a diagram up there. This is the diagram produced by the National Health and Medical Research Council. We have to report on a regular basis as an RTEC, and when we're reporting, these are the milestones that we need to report on in terms of all the activities we're doing. So we have a goal between we've just recently done some strategic planning, and this is our goal from July 2019 to December 2020. So we've got three key strategies around leadership and collaboration. Very much, as I said, we spend a lot of time pulling people together. We're looking at the barriers and the issues that exist in our system and looking at ways perhaps that we can all work together to improve them. We're building expertise through projects and capacity building. That's a lot of work we're doing around building the expertise of the workforce. And of course, that's where consumers fit in. We're also about building the expertise of our consumers to be involved in this research. And we're also developing the statewide translation pathway. So that's about how can we do things to help perhaps a project move along the pathway faster, perhaps to commercialisation. So that's what our work's around. I have actually put in here, sorry, this is a really messy diagram, but I just thought it just gives you some idea of the sorts of activities we're doing as an organisation. It's draft, our board is we're still discussing this with our board, but I thought it's a really good picture of sort of things we're doing. You'll see that we've circled stakeholder engagement there. That's very much around, we actually have a forum that reports directly to the board, and we're meeting in the next couple of weeks, and they provide some input. There are a lot of our foundations and our non-NGOs and so forth. And then you'll see here that a number of our priorities, are very important around consumers. And we've also got a system initiative around increasing consumers and community participation. And finally, that last circle I've got there, which is better care initiatives, they're some of the important projects we're doing, really great opportunities for consumer involvement, and I'm going to talk a little bit about those in the next couple of slides. So importantly, a real game changer for us as an organisation was the Medical Research Future Fund, which is an endowment fund which, when it reaches fruition, should be around $20 billion. So we're starting to see some of that money come through. What is really interesting about this fund, it's actually for priority and strategic-driven research. And it's a little bit about saying, okay, we know the researchers have a lot of great ideas for research, but in this case, this is around, let's find what are the issues and let's develop research to solve some problems. And it's around having that direct impact with health and economic outcomes. And it's additional and complementary to the National Health and Medical Research Council. So we started to see this money come through to us in 2016, actually for projects in 2018. So just to give you a little outline of what we've been doing the last couple of years, we've had 3 rounds of MRF funding that have come through the centre that we have managed. So in round 1 in 2018, we've had very short timelines on all of this funding. It's all very new and it's all being rolled out really rapidly. So in round 1, we had $2 million over 1 year. Because it came up very suddenly and we had very short timeframes, the way that HTSA chose some projects was we very much looked around and to find projects that we call what we called shovel-ready, that already existed, that could deliver an impact in 1 year. So that's what's interesting about this. Impact has to be delivered in 1 year, and that can be very difficult for research projects. So then we went into round 2. Once again, we got $2 million over 1 year. This time we did a little bit differently. We had an open call, and we funded 8 projects. And finally, round 3, which has only just recently been announced, we did that a little bit differently, which I'll talk about, and we got $4 million over 2 years, and we've actually recently approved 4 collaborative projects, as well as some national initiatives. So round 2, just going back to how we ran that process, it was very much a traditional grant application. We had an open call and we got 95 applications. Researchers were asked about how community would be involved in those projects. Then we had a review panel. As you can imagine, very time-consuming, 95 applications. I think we had about 45 people involved in those review panels, so you can imagine it was very resource-intensive. And once again, we felt that possibly it wasn't so much about solving a problem, but it was still a little bit researcher-directed. They had some projects that they wanted funded, and so they were the types of projects that were submitted to us. So we really thought, as great as those projects are, we still had to find a way that we could identify the issues in South Australia and get projects that were going to solve those problems. And just a reminder that Health Consumers Alliance are on our board, and of course the board approved all of those projects, so we did have that representation. Round 3, new approach. I've put this diagram up here. We decided for this one that we would establish a research advisory board working group. We did have a community representative on this board, and this board had to look at all of the things that we needed to take into consideration, and that's what's represented in the circles, including consumer priorities, and identify what should be our priority areas and how we should allocate that next round of funding. We developed 5 strategic priority areas: data-driven healthcare, health services, particularly that interface between acute and primary care, mental health, ageing and Aboriginal health. We then developed a new strategic approach where we were looking for projects that met the new MRFF priorities. They released them in 2018 in November, and our 5 strategic health priority areas which related to South Australia. And then we asked researchers, health services and community members to come together to develop collaborative research projects that would fit those priority areas. So this is a really new way for us to be developing projects. And so we had a roundtable workshop and some collaborative work groups. This was run in February, and I think we had about 100, do we have 120? I think 120 attendees, and we had rooms set aside for each strategic priority area, and we had a co-design process where we got people in the room to try and come up with projects that would address a number of our South Australian issues. They had to be scalable solutions to health services challenges, and by that we mean they had to be things that could go across the whole system. They needed to reflect collaborations between health services, clinicians, researchers, consumers and policy makers, and they had to drive impact in 2 years. There were 2 community members, in some cases more, in each group. And I think the difference here with this one, it was about building that community members and stakeholders into the design process of the research projects. So that was a very new approach. We currently don't have another round for MRFF, but we have tried this new way of doing things. So what would be really great to hear from you today is how you think we could improve on this process, because this is our most recent round. It was, once again, very time intensive, and of course, because we had so many people involved, it was very difficult to bring all the ideas together, and of course there are a whole lot of ideas that we couldn't fund. So it would be really great today if you could have a little think about how you think we could actually improve this process, or maybe we should do something completely different. But we want true collaborations, and the MRFF are actually demanding that there are true collaborations between consumers, stakeholders and researchers and clinicians. So it's no longer just a letter of support from a foundation. It's actually a true collaboration. We want people meaningfully involved in all of our research projects that we do at Health Translation SA. So thank you. I did have one, I didn't talk about the thing, but I will say that this was one of the, I'll just let you know that this was one of the projects that was funded through that round 3. And this is a software platform designed to recognise when people with schizophrenia and bipolar stop taking their medication and intervene before relapse or hospitalisation. So of course it's a really big issue for our hospital system. And so this project has had funding in round 1 and round 2, and round 3 was about taking it even further to statewide. But of course, when the review panel went through this project, they thought, this is a really, we're talking about mental health here, mental health of our community. So we probably need to make sure that there's really significant community engagement in this project, just because of course it's talking about collecting people's data and personal information. So when the review panel looked at the projects in round 3, they made a whole lot of recommendations about how to increase the level of community engagement in that project. So that's the type of thing that we can do in this, in the way that we're running this process. So thanks.
And she didn't get dinged. So thank you very much, Jenny. That was a great presentation from what's happening with Health Translation SA. So the next presentation is from Camille Morelli, and Camille is a public health physician with experience in health policy, health economics and clinical trials management in France, Israel and the US. So she started working last year as a strategic advisor for the Hospital Research Foundation, where she structures the grants allocation processes and works to ensure that the funding has the highest possible impact. So Camille is going to talk to us today about the Hospital Research Foundation's Your Choice grant round. So welcome, Camille.
Good morning, everyone. Right, so I'll just say a few words about the foundation before I get into specifics. So the Hospital Research Foundation fundraises money for medical research. It's South Australian based and gets its income mostly through commercial revenue, through home lotteries, which I know are quite popular in the States. That would be about 80% of our income, and 20% of our income comes from philanthropy work. And so last year we donated $25 million in medical research, which makes us the biggest funder of medical research in the state. Our ability to fundraise so much money completely independently from the government or anything, is purely from the community here, comes from our ability to connect and engage with everyone in the community and to offer the opportunity to donate money for medical research in any disease area. Or any hospital, medical research institute or university in the States. So we want to be, or we are the foundation that connects everyone, and we give the money back to the system, and everyone who gives us money or buys a home lottery ticket gets its money back when they go to the hospital, or when their family or a member of their community goes to the hospital. They can benefit from that donation. So that's in that context that creates the fact that we fund the entire state, and all the hospitals and the local health networks creates unique challenges. Usually foundations focus on one disease area or one hospital, and that makes their allocation of money much more targeted. With us, we fund the entire state. So how best can we spend our money to have the highest impact, while keeping our engagement with the community and keeping that flexibility and giving the opportunity to fund every disease, however rare or common it is. So in that context, we organized that very unique grant round, which we called Our Choice. It was the first time we organized it, even though I'm going to talk about that at the end. We organized something similar a few years ago, before I arrived in the country. So the Your Choice was a new engagement strategy for the Hospital Research Foundation donors and THF home lottery ticket buyers that provides insights into the areas of healthcare that matters most to them, plus give them a say on which projects they wish to be funded. So through a first survey where we give them a choice in which disease area they were interested in, and then through a second survey where we actually gave them a list of projects and they got to choose which one they wanted. Like I said, THF is fully independent and was strongly connected to the community. and it has the ability through its experience and fundraising capacity to create strong connection between donors, researchers, and clinicians. So the first survey, so there was a survey we first sent, the marketing department sent, structured around helping THUF understand the areas of healthcare most important to its supporters and to inform future activity. So we sent it to both our donors and the home lottery ticket buyers, which we consider donors. And we did that electronically and by post. There was a list of 10 disease areas, which included the top 2 winners, which were cancer patient support and aged care, but also pediatrics, obstetrics, and gynecology. Very, I would say it was a lay description of 10 disease areas. And so donors got the opportunity to vote for one of them. The 2 top areas with the most votes were chosen, and then we organized a grand round around it. So we decided to give 2 grants, one for each category of $200,000 each for a 12-month project. And in the guidelines, the eligibility criteria were very clear. It needed to be a clinical and translational project by nature that implied direct contact with the population considered. So that got the researchers a little bit confused sometimes because it wasn't very specific. But still, most people, some people asked us questions, but mostly the applications that we got were all eligible and very much on target. And for example, the direct contact with the population considered meant that, if you're just gonna draw a blood sample from the patient and then go back to your lab and analyze this and do all sorts of tests, then consider that's not enough involvement. There needs to be a direct engagement and direct contact with the population of patients, which have the condition or disease targeted. And the project needed to deliver a tangible impact to the patient, either in hospitals or the community, and that impact must be measurable within 3 years of project completion. So we've got 15 applications, overall very high quality, and then we shortlisted internally with a panel of 3 scientists based on 3 assessment criteria, which were the innovation, translation, quality of the project, the scientific merit of the project, and the track record of the applicant. That allowed us to keep scientific integrity into the process while keeping the donor engagement. We shortlisted 2 applications for aged care and 3 for patient support based on the average weighted scores from the internal panel. And then we sent a second survey to the donors, but only the donors or the ticket buyers who participated in the first survey. We extracted some information from the application form so that there would be a lay summary of each of the 5 projects. And we just put that on a voting slip, and then the donors got to choose 1 project in each category and send us back the information electronically or by post again. And then we announced the winners first to the people who actually voted and then to the general public. So the 2 winners were Professor Bogda Kozvara from Flinders Uni for cancer patient support and Professor Gillian Harvey from Adelaide Uni for aged care. Those 2 projects, we are very, very proud of funding, and we consider really, we really expect them to have a high impact in South Australia and the community. So I'm going to give you a few seconds to read it. So overall, we are very happy with this initiative. I think we were successful in engaging donors and getting the community, interested and involved. But we were also successful in funding 2 translational and very innovative projects by 2 high-level and experienced researchers. And overall, the 5 shortlisted applications had very high scores, and we were very happy with the quality of applications that we've got. So we will definitely consider having another round like that in the future. While we will consider, and it's mostly because it's part of my responsibilities is always ensuring scientific integrity, and so around having a grand round like this, you need a delicate balance between keeping scientific integrity and engaging the donors, and so that's, like I said, it's delicate. So I would consider maybe more developed guidelines, especially around the shortlisting, and we'll think about how we want to organize the final vote, if we want to keep it like that, or if you want to share a vote, for example, 50-50 between the donors of the scientific panel, or another mechanism to organize the final decision. It's a new model, so there's not one way of doing it, but overall, we are very happy with the outcome. And before I finish, I just wanted to mention another initiative, which I think is also very interesting, that we had for our 50th birthday in 2015. Similar approach, except much smaller projects. It was only 2 projects of 25,000 each. And it was only for the Central Adelaide Local Health Network, which we were mostly funding at the time. Like, the fact that we're funding the entire state is recent. Like, back in 2015, we were still mostly giving money to the Central Local Health Network. Same idea, ground round, everyone from the Central Network, researcher, clinician could apply. A scientific panel shortlisted 6 projects. And then the general public, not just the donors, but also the general public, got the final vote for 2 projects. What was really interesting about this round is that the 6 shortlisted applicants had their own crowdfunding video developed by the THF marketing department, so that it would help them raise additional funds through community donation towards their research project. They got their project promoted across, all the various media platforms and, opportunities that THF offers, and they also got a personal media training package. So that's for not just the 2 winners, but all the shortlisted, and I think that was also a good example of how we can also, help make the connection between researchers and the community, but also add to the researchers and help, develop that sensitivity and connection and understanding of, what happens outside the lab and how you can be proactive and have a more entrepreneurial spirit, I would say. So I thought that was also an interesting initiative. So I would consider keeping that if we're going to do that round again. Maybe that we're going to add that to the mix. That's it.
Thank you, Camille. So moving along, everyone's welcome to hop up and move around and get a drink if you need. And now our final presentation. So I'd like to welcome Sarah Bray and Marjorie Schultz. Dr. Sarah Bray is the Project Manager and Consumer Engagement Officer for the Registry of Senior Australians, ROSA, as it's known, based at SAHMRI. Over the last 2 years in this role, she's helped establish and develop ROSA's framework, including the development of consumer engagement procedures, strategy and practical tools. Sarah facilitates consumer involvement in ROSA and coordinates community engagement activities for the team. Marjorie Schultz is a consumer representative on the ROSA Research and Consumer and Community Engagement Committee. Marjorie is a former pharmacist with tertiary qualifications in public policy and management, and has around 30 years practical experience as a member of not-for-profit boards in private health, aged care and disability sectors. She was awarded an Order of Australia Medal, OAM, in 2002 in recognition of her services to local government and community, particularly through health and human service organisations. So we'll welcome Sarah and Marjorie up to talk to their presentation, which is Rosa and our community voices. And on the completion of their presentation, Jenny and Camille will join them for our Q&A session. Thank you.
First of all, I'd just like to acknowledge that we're meeting on Kaurna land. It always will be and always was Kaurna land. And I'd like to pay my respects to all the elders in the room from Kaurna and all Aboriginal and Torres Strait Islander clans. And I would also like to acknowledge the Aboriginal and Torres Strait Islanders in this room today. So before we start, I just wanted to let you know a little bit about ROSA, or the Registry of Senior Australians. Why do we have one? Basically, our population is ageing in Australia as it is all around the world. Older people are consumers of health and aged care services. This isn't to say that they shouldn't be and that they shouldn't be receiving services, but at the moment older people are receiving 41% of the hospitalisations. They account for 48% of the days spent in hospital, and there's many questions that remain about how appropriate the care is, how effective it is, what kind of variation there is between the services, what the best models of care are based on real evidence in both the aged care and the healthcare sectors. And we think there's many opportunities that exist to improve the systems regarding innovative services or more appropriate models of care. So our work is a big collaborative group. So we have all the different universities involved, Adelaide Uni, Flinders Uni and Uni SA. Also we have SA Health involved. We have consumer representative organisations such as COTA, Council on the Ageing, and Health Consumers Alliance. We have aged care providers involved, like Silver Chain, ECH and Helping Hand, and we have the primary health networks. So we're a whole big collaborative organisation of clinicians, researchers, consumer advocacy groups and industry partners, all trying to find the best solutions for the aged care and healthcare systems for older people. We have a team of 12 people based at SAHMRI who are the core research group, and that's the photo up on the screen. We're a whole group of people with different backgrounds. There's epidemiologists, there's people who are expert in dementia or arthritis, all sorts of backgrounds. What we do is we analyse information that's routinely collected by the government from the aged care or the healthcare sectors. We have these linked up together so we can understand better how the two systems interact, how someone journeys through their older years, and the information that's already collected might be what services they're using in the aged care, could be what health care system use they are using, like the hospitals or Medicare or their pharmaceutical scripts. And we use all this routinely collected information to then provide evidence back to help guide decision making to improve the quality and the safety of the aged care and the healthcare sectors. We hope to provide evidence that will then allow more innovative and effective and age-friendly services to be developed. And a lot of this information that we're working on is of interest and to the real world, and the Royal Commission, for instance, has been very interested in a lot of the work we're doing, work around antipsychotic use in residential aged care, the prevalence of dementia in the community who are using aged care. And so a lot of the work we're doing, we're confident is actually going to make a real difference to the older people in Australia. We have consumer and aged care providers represented at our governance level of ROSA. So we have a steering committee which has members of all those different organisations that are involved, including COTA and Health Consumers Alliance. But then we also have an executive committee, a research committee and a data linkage committee, which all have consumer representatives sitting on those committees. And then we have a dedicated consumer and community committee, as you can see pictured here. And I think some of our consumer representatives are in the room today. And so our consumers in that committee are the ones that are represented on all our subcommittees, plus there are another 3 people from the community that are involved in that committee. We also have COTA and Health Consumers Alliance involved. So the consumers on this committee help provide advice into all different aspects of the ROSA work. They give us advice and feedback and input into grant application proposals, research plans. They help give us insight into some of our findings and results. They help us develop the documentation for a lot of the work that we do that faces the community. So, for instance, developing our consent forms and participant information sheets. They helped us make summary sheets that were in language that's appropriate for older people. They also help us with our plans for consumer engagement activities, and at the moment we're currently developing one with COTA's plug-in team, and our consumer advisory group definitely had a lot of input into that. So today, for the rest of the talk, we're going to focus on one example of a project that our consumers definitely had positive impact on, and I'm going to hand over to Marjorie to tell you more about that project.
Thanks, Sarah. So Sarah and I, in talking about this, decided that a case study would be the most effective way that we could show you positive examples of community involvement in the ROSA processes. And so we're using the Redefining Healthy Ageing Together symposium. So this was a Frontiers of Science symposium offered by the Australian Academy of Science on a range of topics for early mid-career researchers. EMCRS, yet another acronym to get your head around as you come involved with ROSA and SAHMRI, but we get there. The Academy offers 3 to 5 symposiums per year and via a competitive grant process. So the ROSA proposal, led by Dr. Stephanie Harrison, was for healthy ageing, was successful. So we're all very excited about that. And ROSA's proposal included an EMCR workshop on consumer engagement, and on the second day, a half-day intergenerational public session. A little bit of discussion on the organising committee about the word public session. Was it going to be consumer? Was it going to be community? We agreed in the end that public session was the way to go. So the organising committee included representatives from the Academy, EMCRs from around Australia, and 2 consumer reps, myself and George Turley. And we got to be there. Sarah had sent out an expression of interest looking for a consumer representative to be on the organising committee. George and I both put our hands up, and Sarah and Steph, in their wisdom, said, let's have both of them. So George and I were actively involved in the planning and execution stages, and I think we had a really positive impact. So the organising committee met quite frequently via a Zoom teleconference. That was a first for George and I, and so we came in here to SAHMRI and met with Sarah and Steph and Maria at times. But you know, if we'd been a bit more IT tech savvy, we could have done that from home. We didn't actually need to come into SAHMRI. So our input in the planning stages, we reviewed the grant application initially. We formulated the name with the together wording. It actually, you know, it had to be Redefining Healthy Ageing because that was guidelines that Steph had worked under, but we were really, really keen to have that together word there, so we worked on that. And we had significant input on speakers from within the guidelines, of course, but from our experience of attending various forums and lectures and things around the state that who we thought was interesting, might be a good idea. And in the execution stage. So unfortunately, When we got to the execution stage, I actually got ill, so I wasn't around a lot in the execution stage. But we reviewed the abstracts when the call for abstracts went out. George and, all the organising committee reviewed the abstracts. And we had a lot of input on the format, and also George and, because I wasn't there, George and other community members of the ROSA committees facilitated some of the workshops during the symposium. So the symposium ran over 2 days, and the first day included, obviously, was based on presentations from EMCRs and a consumer engagement workshop, and they were facilitated by some of the other community members of the ROSA's committees. And then the highlight for me about the symposium was the second morning, a half-morning public session, which was available to any members of the community who heard about it, free, and were able to come. So the Academy advertised the public session on Eventbrite, and ROSA had just started through our networks with COTA and HTSA, and were also planning to advertise in the senior newspaper. But the event booked out in a couple of days, so never got to be advertised in the senior newspaper. But for me, that was significant. 50 people put their hands up to grab those 50 places from Eventbrite in the first couple of days. So we had approximately 60 researchers and 50 members of their public attending. And as I said before, consumer engagement workshop for researchers on day 1 included facilitation by ROSA consumers. And then on day 2, there was a panel discussion as the kick-off point for the public session, moderated by Jane Mazarade from COTA, and the panel members are there, Graham Ack and Penelope McMillan, who's going to take over here in a minute, Ian Gladstone and Judy Smith. So the whole event received really positive feedback, and this slide shows you, with all these things, the evaluation was pretty poor when you think there were 60 researchers there. But anyhow, what was your main motivation to attend? The first tick, nobody said the attend public engagement workshop session. What was the highlight of the event? Look how the numbers changed. 53%, the public engagement session was the highlight for them. Did you engage with members of the public during the session? 65 said yes. And did you learn something practical to help you engage more effectively with the public in the future? 70% said yes. And that morning session, that second day session, ended up with everybody having a lovely morning tea and a chat, and Sarah's got a great photo for us to end up with. So the challenges we had to overcome: the grant application template did not explicitly seek consumer involvement. The ROSA researchers invited involvement from the ROSA Consumer Committee. The budget guidelines for the grant did not explicitly include any consumer costs. ROSA requested consumer representation incidentals of $1,000, and that went into the budget of Steph's proposal. And the grant was successful, including that $1,000 for consumer costs. Yet the funding body didn't have any mechanism in place for consumer reimbursement. So ROSA came to the fore. They reimbursed George and I from their own cost centres, and then reclaimed the money by invoicing the Academy. So that it was probably the biggest challenge, wasn't it, Sarah, in terms of community involvement? There were lots of other challenges, but that was probably the biggest challenge and a point to remember.
So I'll just finish off now with a couple of points about what we learned and some take-home messages from this case study. First of all, the collaboration between the consumers and the researchers was very valuable, and it wasn't just a tokenistic thing. We actually got input from the consumers in all the way through, from the preparation to the execution, and it, I think, made the event a much better event than it would have been otherwise. It also highlighted that barriers do exist. Co-design between researchers and consumers is not yet business as usual in all research groups, or even for all funders of research. It's still quite new, and it takes a lot of learning and work from both sides. While some researchers may have less appetite than the consumers for doing this co-design, I think some of this, at least I think a lot of it actually relates to barriers or perceived barriers by the researchers, because it isn't business as usual yet. And the more that we provide tools and opportunities to skill both the researchers and the consumers to bring them together, the easier this will become. As a side comment to the feedback survey, I heard from HCA that some of the early career researchers at the conference followed up with contacting HCA with proposals to try and involve consumers with their research, but then Health Consumers Alliance kindly helped them with those proposals and developing them, but then when they took them back to their senior research groups, they weren't that keen to follow through. And so I guess that also shows you another barrier. From the earlier levels may be more keen than sometimes the more established researchers. Of course, this is just a generalisation. But take-home messages. Effective consumer researcher collaboration takes time and planning and resources and goodwill on both sides, but it's worth it. If you provide workshops and opportunities for researchers and consumers to come together and to talk about practical tips, what worked for them, what were the barriers, how did they overcome them, that all helps the next group to be able to do the same thing or do it better. And I think the most important part of consumer and researcher involvement is building a good, strong relationship at the beginning, because it is a learning experience for both sides, and so you need to have that good relationship and foundation and goodwill to make it work, because it's not always like as easy as you might expect. It can be a bit like squishing a square peg into a round hole, but sometimes you can make it work.
Thank you.
Maybe we could ask everyone up to the panel. So Sarah, Marjorie and Jen and Camille. So thank you very much for your presentation, all of you. We've got time for a few questions, and then following that we have we're going to move straight into table discussion around research policy setting before we break for morning tea. So that suits everybody. We've got a message to say that the bathrooms, toilets here aren't working. We may need to go across to the RA, which is just across the courtyard. So keep that in mind for morning tea. Don't hang on too long, I think the advice might be. So that's just come through. So before we move into the questions, I think that what we've had is a presentation of information that the program committee structured from last year's evaluation around examples of consumer engagement in research. I think that Marjorie referred to Penelope McMillan, who would have chaired this session and had prepared this session with the program group. However, at the last minute wasn't available today, so she won't be here. So I think it's probably time to concentrate back on the panel, and there's some roving mics. Nicole has one down the back, and you have one down the back as well. So if people want to pop their hand up and perhaps just let us know who they are and ask their question, We've got about 10 minutes to do that in, if that suits everybody. Okay, Bob, here comes Nicole. Yeah, thank you.
Yes, thank you. Bob Reeson, retired GP. I'd like to ask the panel, has any research been done on the consumers that have applied and got involved in all of this? What are there, any analysis of what's driven them to get involved, and can you make anything of that?
There may be, apart from responses from the panel, other people that have examples of that as well. So, did you want to start, Sarah?
Hi, Bob. That's a good question, and it's something that we've actually been thinking about ourselves, but to date haven't done. Partly for two reasons. One, our consumer representative group is a small sample, really, of 8 people, so you can't make too many extrapolations from research on one little group and one example case study. And also, too, that sort of study would require ethics, and we hadn't put in any ethics applications for this when we were setting up our governance structure. But it's definitely something that a lot of researchers are thinking about and wondering not just what's motivating the consumers or community members to be involved, but also how effective the consumer engagement and co-design is, and how do you measure that?
Thanks, Sarah. Jen, did you have a... oh, sorry, Marjorie, yeah.
Sorry? Why did I become involved? Sarah just asked me. And the answer to that was I had only just retired and I saw an expression of interest on the HTSA website, which was a paid exercise by Rosa. And I thought, oh, that's all right, put my hand up. My concern has always been how consumer representative am I as one of 8 people. But I'm really impressed with what Rosa is doing, in increasing the pool, and the current example that Sarah mentioned briefly, the work with Cota's plugin. What we've asked them to do is to do the project is based on how consumers get their information about current research. Is it through the Women's Weekly and the hairdressers? Is it online? Is it from your GP online? And that is going to encompass a couple of hundred people. And so we're spreading the pool,
Thanks, Marjorie. And Jen, did you have a...
Hello? I think that more broadly, in terms of research around consumer involvement, I think there is a large body of work that relates to patient-centred care and consumer involvement in health services. So I think a lot of that research is probably really useful in terms of consumer involvement in health research. So I do think there is a large body of work which supports the idea and the value of consumers being involved in research. I think Alex mentioned too that we're currently looking at doing some work nationally around the value of consumers in research, because we think that's a piece of work we really need to do, because I think we're still needing to convince the researchers that our consumers add value. And I think in many cases in the past, a number of researchers have think that things like focus groups that they do as part of the testing of their projects is consumer engagement. And we want that broadened to not, it's beyond that. It's about co-design, it's about meaningful participation, and it's getting, mutual rewards from that participation. So I think we really need that piece of work that ARA is currently doing, which can say to the researchers, this is the value you will get. We know that there's a value, but we need that document, we need that evidence to give to the researchers and say, and here's the evidence. So, yeah, really important piece of work.
Thanks, Jenny, Sarah, Marjorie. Is there another question? Yeah, Sharon, Nick's coming behind.
Hello, Sharon Law, and I'm a member of the reference group, but also from Flinders Uni. My question is similar to Bob's, and it relates to the ethics process. A lot of the conversations about, once you've got the money, you've got the project, but the ethics process is a really important part of it. Do you see that nationally and at a state level and locally, that we'll ever get to a point where there'll be solid consumer representation on ethics committees, given that there are some concerns about one of the current, the ethics of one of the current projects that's been funded through MRFF? And what do you think that would look like, given that it's such a diverse area?
Sure. Any comments, Jen? Or try Sarah's.
It's certainly, from Health Translation SA's point of view, it's probably one of the really significant system barriers that we've identified in terms of all research in South Australia. So it has been identified as system issues. System issues are the types of things that we as Health Translation SA want to work on. We're currently doing some projects around data, because that's another significant issue that's affecting research in this state. And there also is some discussions taking place about research governance, including ethics and so forth. So it has been identified, and as I said, there is some discussions, but yeah, that's probably stay tuned, I'd say, to that one. But yes, absolutely identified as a major barrier to, and particularly when you've got the MRFF wanting projects completed within a year. So, I was at a meeting with one of our projects yesterday, and, the first 3 months they couldn't commence with their interviews because of the ethics. So certainly, yeah, it's a big issue.
Thanks, Jen. And Maria, did you want to comment? Thank you.
Yes, I had a question for Camille, actually. In regards, is that all right?
Yeah.
In regards to what the Hospital Research Foundation is doing to assess consumer engagement within the projects that they're funding as well, is that part of the criteria for your grant funding now? And are you considering that to make as a requirement that the projects do involve people and that there is a, direct public involvement on the projects?
Right now, it's not a requirement. Mostly what we've done with consumer engagement is what I talked during the presentation. I think, yes, I think I would like it to become part of the requirements in the future. I think that it might take us a few years to get there. I'm not going to lie. We've recently, like the amount of funding that we have now is recent. And so there's a lot of structuring and a lot of things and processes to implement first before we get there. But internally, we definitely see, how important, consumer engagement is. And yes, eventually, I would like it to become part of the requirements. And I think in general, as a funding body, I understand that we have a lot to say about the way the research is being done, and we have a lot of that gives us a lot of responsibilities, and so that's how I look at it. I think, yeah, we do have we can have a lot of influence with the requirements about our grants process, about consumer engagement, but also other things. So I take this seriously.
Thanks, Camille. Maria. And Tony, a question?
Yes. Thank you. Tony Sangster, in addition to the other introduction, I'm a healthcare consumer and advocate, a retired clinician, and a person with lived experience. My question is, I guess, mainly directed at Camille, but other members may wish to come to this. Evidence-based medicine is taking a beating related to a number of things that people read and people, researchers and experts that have also commented on this. So, and my concern is that clinicians seem to be very conservative, not necessarily up to date with some of the bad science that is out there, and that this could influence the grant process, or at least the, and also the fact that there isn't a person with lived experience on that researcher panel to make decisions. So I'm wondering how you might overcome this obstruction, really, in terms of what science is believed and how obstructed clinicians may be in the process.
Thanks, Tony.
Good question.
Yeah, it's similar in a way to consumer engagement, but a little more detail about people with lived experience being represented. Yeah.
Yeah. So so I would have a similar answer. I think there needs to be an engagement from that type of people, a consumer during the process. During the ground round process, there's only a few stages or moments where you can have that involvement, and it's really during the code design at the beginning. So it would be the responsibility of the researcher to organize this with the help of his institution. The next step is during the assessment process. So there's an option there to have a representation in a panel of assessors, which is something that I'm very open to do. And I would, after that, that would be the main two steps, because usually after that you might have a multi-step process to shortlist or decide which applications make it through. But once this is done, the last opportunity you have is when, for example, like one of the things I'm working on is assessing impact of our projects, which is another, no one knows what's the best way to do that yet, and there's a lot of discussions around it, but what we know is that impact is shaped from the beginning. So you have an opportunity once you start a project to sit down and maybe, discuss and say, well, what about this, and how about, you need to engage with stakeholders, and what about, have you engaged with that type of people and done this? So there's an opportunity there as well. And again, in the future, it might take a few years because we're developing our structure. But there's an opportunity to do that here. So that's
okay. So it's on the agenda, Camille, and today might be a good opportunity to network with people with ideas around lived experience and community engagement too, to be helpful. Another question we have.
Hi, I'm Vicky Bedford. I'm just a consumer advocate as well. This question's for Jenny, actually. You said you have you're trying to build capacity for your consumers. So could you kind of elaborate on that? And then the second part was your review panels also include community members. Are those specific to whatever the research is? Are you making sure that their lived experience is matching up to what the research is so they have relevant input?
Sure. Well, Alex Mickelmore actually works for HTSA 0.5, so half-time with us. So very much the work that Alex is doing is around supporting the work that we're doing. So all of the register and so forth, all of those activities are related to. So in terms of what we're doing around capacity building, that's very much the work that Alex is doing. In terms of our review panels for our research projects and so forth, the register's only recently been established, so we've had we've had some consumers that have shown an interest very early on in terms of our work, but of course that pool's going to grow a lot more now that we've got the register. But in terms of having people with lived experience on those review panels, we haven't had a large pool of people that have been interested in being in our research review, so probably not necessarily. But I guess our assessment criteria is such that the things that we're looking at in terms of scalability and so forth, it's more about fulfilling those requirements than the actual content. But as I showed you with that mental health project, we did actually, a number of people on that review panel drew attention to the fact that we're talking about a mental health project, and therefore the consumer engagement needed to be much stronger. So I think there is that general idea and understanding of the role of consumer engagement in whatever theme the research project has. But as we develop the projects more and we have more opportunities to run research projects in a collaborative way, we will of course do more of that matching of the lived experience and so forth with the project itself.
Thank you. I think, Julia wants a question. Yeah, just the Microphone's coming, yeah.
Just to follow up, so when the recruiting took place for that last round, it came through HTSA and we did match consumers to the specific priority groups. We also managed, we got Leland involved, which is the Lived Experience Leadership and Advocacy Network, so they have a lived experience of mental health, so we made sure that they were involved in that priority group to make sure that there were people with lived experiences within each of the priority sort of set topics.
Okay. Thanks, Julia.
So Julie is the board member for
Yeah.
HTSA from Health Consumers Alliance, for anyone who doesn't know Julia.
Yeah. Thanks. I think we might stop there. Is that okay? There'll be a lot of opportunity to chat more in the roundtable work, which we're moving into. So the table discussions, the first table discussion is up on the slide. And we're looking at what strategies or learnings from presentations do you think would work best in future research priority setting activities. So we've started to talk about some of that with the question answer, and you've seen some examples. So as far as the tables go, there's a table facilitator on each of your tables, and I'd ask them to put their hands up. Julia? Tony? Anyone not got a facilitator? Want to join another table? That might be, there's so Mario, are you on a table? Yep, so there's one there. Irene, you're on a table, great. And Tony and Sharon, you're here. Julia, it's just the middle. Caroline's here. And Mike I haven't seen. And Jenny. And Akushla. Yeah. Okay, so maybe join a table, and if you think you've got too few, perhaps join another table. So I understand that what you'll do is discuss this question on your table. Is that right, Alex? That's what we're going to do, discuss this question on each table, and the facilitator will help move that along, and the facilitator will also provide some notes at the end, which after morning tea we'll have a look at some of the outcomes. So does that fit with everybody? Yeah? Okay, thank you. You haven't got any? Hi everyone. Hello, can I ask you to bring your morning tea back to the table that you were on? If we could do that, and thank you very much for the advice that I received from 6 tables, and I'll talk to that at the end of the next session. I'd also like to welcome the people that have joined over the last 20 minutes or so, members of the CAG and community members. But we're pretty much ready now to move into another important aspect of the program, which the evaluation advised us about, which was providing advice on another piece of work that we've been involved in. So once again, on each of the tables, there'll be a table leader, and this time the main change will be that it won't be this Ellen that leads this piece of work. We have another Ellen on our consumer advisory group, Ellen Skadzian, and she's currently the CEO for Down Syndrome Australia. Ellen is passionate about supporting the involvement of consumers in research, policy and advocacy work, and she established the Consumer Dementia Research Network at Alzheimer's Australia, as well as the Down Syndrome Advisory Network. And we enjoy having Ellen on our committee or advisory group, and she's been leading a piece of work which is relevant to the next table discussion. So I'll introduce Ellen and then we'll take it from there. So thanks for coming back, and tea and coffee and toilets seem to be working. Good.
Thanks, Ellen. I'm really excited to be able to be part of today and to hear all of the wonderful presentations that we've had so far. What we wanted to do in this next session is actually to get you involved in helping us with our toolkit. So as Alex talked about, we've designed a toolkit to try and help bridge some of the gaps in terms of the difficulties people have in involving consumers. We want to see consumer involvement in every research project, and we want to see it done well. So one of the things that researchers sometimes tell us is that it's too hard, it's too difficult, takes too much time. And so the toolkit is really designed to be able to say, here's a way to do this. You don't have to reinvent the wheel. There's other people who've done really good things, and you can take some of that information and move forward. We thought the forum today would be a chance to capture some ideas from community members and researchers about the best way to involve consumers. So that's what we're going to do today. I'll ask that each table picks a scribe, takes good notes. We will be taking away the sheets that you work on today and using them to create a resource for the toolkit. So what you do today is really important. What we'll do, you'll see we've got some topics listed here, and what I'll ask is that each table picks a topic to work on. It's fine if different tables are working on the same topic, that's no problem, so you don't have to feel like they have to be equally shared. And just brainstorm your ideas. We don't have a lot of time, unfortunately, so just throw out your ideas. And at the end of this session, what we'll do is go around to each table and just ask you to share your top tip from your table, the thing that you think was most interesting. Try not to repeat what other people might have said, but we will take all of your ideas and use them, as I've said. So the topics, I'll just give you a brief outline of what we were thinking. So communication, and that's around how to make communication work well for both the consumers or community members and also the researchers. Consumers sometimes tell us they don't hear from a researcher for 6 months, and that's a problem for them. Relationships, so this is about creating productive, professional, positive relationships between consumers and researchers. We've heard great examples of when those relationships go well, but we also know sometimes there can be breakdowns, so we want to know your tips to how you make that work well. Research translation, again, this is about putting research into practice. How can we best get consumers or community members involved in doing that work? Involving new people, this is a really important one. Sometimes we find that the same people show up to these forums, the same people put their hand up to be involved in projects. We want to hear your tips for getting new people involved and making this a welcoming process. And lastly, embedding engagement. And this one is around what do you do as an organization to make sure that consumer involvement is embedded in what we do. So we heard some things from Health Translation about the work that they're doing. We've heard from others about different strategies. So we want to hear your ideas about how you do that well. So like I said, each table should pick a topic and just brainstorm some ideas. And also, if along the way you come up with some ideas about resources that you think we should be developing as part of the toolkit, make sure you write those down as well, because we're open to hearing about those as well. So good luck, and we have, I think, about 15 minutes to work on this. Yes? Would people prefer that we delegate topics? Okay, that's fine. We started with that idea and changed our mind, so we can come back to this. All right, so we might just have this table do communication, that table do relationships, the back table do research translation, you guys do involving new people, and you can do embedding engagement in an organization. And if you want to move tables and go to a different topic, you could do that as well. Does that work? People happy? Yeah. So unfortunately, we've run out of time for these excellent conversations. Hopefully you've all taken really good notes so that we can take these away and incorporate them into the resources we're developing. I'll just give you a minute to finish your conversations. So what we'll do now is just briefly go to each table, and if you can just give me the top tip that you've come up with, or a brief summary of some of the discussion you've had. And like I said, we'll still take away everything you've discussed in terms of the papers and combine them and use them as an outcome from this meeting. But just to get a sense of what the conversations were like, it'd be great to have someone from each table share a little bit about what you discussed. I might start over here. Oh, do we have a microphone? Oh, sorry.
That's on? Yep. So we had a broad discussion around literacy in our communication topic. And it was very much about the language, so literacy around IT, literacy around acronyms, but also the whole structure of the collaboration, the literacy around that. So we talked about horizontal communication rather than it being, tends to be one-sided, the structure. So, we have research committees that have minutes, agendas, meetings, call people in, the one or two consumers that had joined the panel. And why couldn't it be flipped to, why can't the meeting happen around a kitchen table? Why can't it happen out in a group? We've got this formula for consumer engagement in research, and it often is just this formulaic one or two people on the research reference group, whereas we were thinking it could be something different to that. So not people coming in, so the going out part of that as an ongoing part of the research group driving it. Yeah.
Great, thank you very much. That's fabulous.
Hi, Irene Ashley here, Table 3. Had a really, engrossing discussion about a range of things. I guess we had the topic of involving new people, and one conversation was really around getting out of the city away from SAHMRI. Not that we don't like SAHMRI at all, we love it, but it's meeting the needs of perhaps going out to outer regional suburbs, having a commitment to that, having a regular routine, community group settings, outreach, regular presence. So these are just dot points here. Having a coordinated approach to go to remote communities. Bit like somehow the suggestion of COTA has a peer education program where there's training attached to people to go out and present, and they go to different venues. And we also have, if we really genuine value for diversity, who are our representatives to reflect our community? We've also got the multicultural aspects, and we need really probably to think about communication techniques for presentations. Not everybody can assume to have great presentation skills. It is a skill, and that needs to be perhaps thought about. Another suggestion was the use of social media in some instances, for instance, around the aged or elderly. Engaging with support groups, perhaps carers networks, and professional networks. And we came up with another thought that harnessing retirees from all walks of life to become involved with community engagement so that their experience when they retire isn't wasted and still valued. and perhaps we could look at how they could be informed from various professional organisations or associations that they may be still a part of but not working.
Great. Thank you.
I'm going to hand it over to someone else in a minute. We're on embedding engagement. We had a lot of discussion, obviously there. We had a lot of things that came up. I think, and asking what is the most important tip, I think if you want to be serious with research, I think we should try and employ people like they do as per like peer works, etc. Because I think once you do that, whether it's like a 0.2 or whatever, it's some sort of commitment and engages obviously the people into the research, and the researcher obviously then is comfortable that they know that they've got that person to rely on. So that one was the highest one for us. Did you want to talk about yours, or? They'll take it away. Okay. Thanks.
Thank you.
Technical difficulties at table 10. We had a great discussion here, and we had research translation, and we went a little bit rogue because we kind of figured that all of the topics fit under research translation. The general top tips we had were that it's really important to communicate the real world impact of research to the community, and that the pointy end of translating research into practice is actually where the rubber hits the road for patients and community members, and that perhaps we do a really good job of showcasing and having great fanfare for basic research discoveries in mice that are going to cure cancer or something like that, but perhaps we need to create the same amount of fanfare and celebration for when research, for however long it's taken, actually makes it into the hospital or primary care setting or community setting and achieves impact. We also talked about the importance of building understanding in the research and general community around what we mean when we say research translation, and perhaps some sort of understanding of what that process is and what the timing can look like, as well as really then honing down on the fact that people with lived experience are an extremely valuable source of knowledge, and often there are some great ideas that come up in community that do not make it through this research translation pathway, and can we give some consideration to working out how we can identify when that research gets stuck along a pathway, and who are the appropriate people that could move it along, and what the different pathways to impact might look like. So who can move the research forward?
Great, thank you.
So we weren't allocated one, but we just made the decision we were going to talk about embedding engagement. And we talked about different methods for different stages, whether the kind of outcomes you're looking for are kind of downstream, like one, they say there's 3 different research proposals and you're deciding between one of those, versus upstream, as in you're looking to kind of visions of different healthy futures for South Australia and what different methods might be appropriate. We talked about participatory budgeting a little bit as a potential, or like deliberative voting methods. And we spent a bit of time talking about representative versus inclusive participation and how it can be tricky to have both. And kind of trade-offs in that space as well.
Thank you, and sorry for not allocating.
That's okay, we were fine with you.
It won't surprise anyone that we also went rogue. We were allocated relationships, so they're the tips I'll give you, but our page has tips across all areas. The feeling was that obviously relationships, they need to be genuine relationships. It's a two-way, backwards and forwards sort of thing. We need to look at managing expectations. So this was about the 6 months communication, so the relationships needs to be clear. What is the relationship that you are actually entering into with the research and consumers' involvement? Clarification about the research needs to be in plain English and not the research proposal that may have won the grant. Removing jargon. We also suggested using or piggybacking on existing relationships or affiliations between consumers and peak bodies. So you've got a few around the table: Alzheimer's, Down syndrome, arthritis, COTA, HTSA. You don't need to start those relationships from scratch. If you go through those peak bodies who also have a consumer based to their operations, then you're already getting a relationship that's already hitting the road. So use that.
Great, thank you everyone. I think it sounds like you've had very valuable conversations, and I really look forward to being able to read through everything that's come through. And we will certainly be incorporating this information into our documents for the toolkit, and we will pass that information back to the participants in terms of how your feedback has been incorporated. So thank you so much. And I will pass back to Ellen. I think I've overstepped my time a little bit, so Ellen's going to be providing a summary of the other table discussion.
So the other Ellen's back. What I did was have a look at the information that you provided on the question at your tables. So there was 6 lots of information that came back. I've taken 2 from each of the tables. However, what I used to sort of guide that was things that we hadn't heard before, and also things that were repeated quite a few times. But to just confirm, as Ellen said, you'll get a copy of everything, but also this will feed back into our consumer advisory group for utilisation as we go forward. So one table talked about explicit and clearer mechanisms for acknowledging consumer engagement and a budget payment mechanism and guidelines that will be repeated as I go through. They also talked about ethical concerns. Design of research is influenced right back at the ethics point. So that was 2 from there. 2 from another table: consumer involvement in directing focus on health promotion and prevention activities. For example, community connection, so that fitted under this topic. And again, grant applications should explicitly state the need for co-design and development of the problem. Again, this table, relationships between consumers and researchers, is way behind relationships between health services and consumers. Giving a say for where research should be done is a role for consumers. Another table talked about people having little understanding of health or health literacy, and there should be some co-design projects aligned with this. They also talked about advocating to change the system process so it's compulsory. For example, do you advocate to NH and MRC to make consumer engagement a compulsory section on a grant application? Something we've been talking about. So it's good to see that come up again. My apologies. The next table, include people with lived experience on all panels or all opportunities in consumer engagement. Training for researchers and people with lived experience, demystifying research, putting both researchers and consumers in the room, which we're always trying to do, and we've done that a little today. Building confidence in consumers in order to be able to engage with researchers, choosing researchers carefully for these workshops. There's quite a few sub-points under that, so we'll just have one from that table. The stage of involvement is really important, and the representation needs to be 2 or more consumers, and consumers and health ethics. Consumers on Health Ethics Committee, and that had 3 or 4 stars against it. and it included the role of ethics committees. So we had some repetition around that. And lastly, explicit and clearer mechanisms for acknowledging consumer engagement and budget payment mechanisms guidelines, and again, ethical concerns. So they were the themes that came through. There's many other points, but we'll collate all of those and get those out to you to have a look at. And as I said, we'll pick those up in the work that we do going forward. And now I'd like to introduce Tony Sangster, who will conclude. So Tony was the consumer lead on developing the program with Alex. So thanks, Tony.
Thank you, Ellen. My task, I guess, is not to be dinged by you all wanting to leave, but we may start with perhaps just going over the outcomes and hope that some, if not all, of these have been met in some way for you all, plus other outcomes, personal ones that you may have had. May I reassure you that there is a feedback form, but it's not to be done now. It'll be emailed out to you. So we hope that will also help you be able to get away sooner, and also you'll have some time to reflect on things before answering that. Similarly, the slides from the presenters will also be put on the HTSA website, as well as the summaries from the workshop. And there will be the recording of this will be available as well, and will go out to other people in the community, including rural people, and we're hoping that they will also feedback into the feedback. They'll have an opportunity for the questionnaire as well. One of my favourite comedy programs, well, two of them in fact, are Yes Minister and Yes Prime Minister, based on in the UK. And in one of these sessions, the Minister was aghast to find that there was a hospital running that had no patients in it. And this was running quite happily with the help of the UK Public Service. The thing is that a forum like this cannot run without attendees, without you all participating. So I thank you all for attending. I leave the matter of whether the public service could actually generate what you've proposed by themselves as outside this meeting. In particular, also to thank the presenters and facilitators. So there's Jenny, Camille, Sarah and Marjorie, and the two Ellens that were the facilitators. And to not forget that there are other people who were involved in this that weren't able to attend today, and that's particularly Steve, the CEO, Wendy, and Penelope. To thank the Forum Committee that made this all possible, and in particular to thank Alex, who did the lion's share of the work involved in this. There's also Ellen's working group and Alex's group with a toolkit. That is obviously an ongoing project and very valuable. And Carolyn involved as well, and again Wendy. Again, just like to emphasise that there is a community interest register, and hope that we are all consumers, whether we also are a professional, a researcher, whatever. We're all consumers, so all of us have a right to contribute, and therefore, registering is a way to help us all be able to have a say. And finally, a particular plug for Carol, regarding No Australian Dying of Bowel Cancer Initiative. And Carolyn, could you please wave your hand, let us know you're there? Yep. Okay. In terms of, and Carolyn, you're interested in people that could contribute, consumers that could contribute to this study. Is that right? Yep. So you could see Carol, and we'll make the contact available as well. Yep, there's a poster there. So unless there are any burning questions, comments or whatever, I declare the meeting closed.